So a couple just introductory things. Sorry I used the formal slide. Like, we're among friends here. You don't need to see that stuff. Anyway, and I have no relationships with the industry. But before I get into this, let me just say we had a fabulous day on Saturday. A number of us were able to attend the 325th anniversary of the incorporation of the town of Framingham. There was a great spread on the town green up north of here. And we had a booth that was easily the busiest booth at the whole place. People were just fascinated to learn about the heart study. Yes, they were attracted by the free cookies. Yes, they were, but they stayed and they talked. And it was really, really great to see. And I bet we gave away hundreds and hundreds of cookies. We collected probably close to 200 surveys about how we can honor the town and the participants. So getting their input and just lots of great conversations. So it was a really exciting thing. And I think, it's sort of the beginning of more engagement with the community and more letting people know what this study has meant to them and what they've meant to us and how they've changed the world. And, I think we need those kinds of messages about the importance of science these days, especially. So I think we're going to try to be doing more things like that. If you would like to provide your input on how we can honor the town, commemorate the study, commemorate the participants, please scan that barcode. And it's a very quick 3-question questionnaire asking, what might it look like? Angela created a couple of mock-ups here of what a statue or a memorial might look like. But if you have other thoughts about what you think that should look like, we had an idea of 15,447 bricks, one for each participant, or a fountain, or sky's the limit. So if you have a great idea, please put it down in the survey. And then the other question is, where should we put it? Cushing Park, on the rail trail. Other people had other great ideas. So we'd love to have your input on all of this. So please at least load it now, and then you can answer the questions later. And if you're not enjoying the talk, please do the questionnaire instead. Totally fine and understandable. Now I'm going to warn you all because we're kind of in close quarters. So my sister, who's a huge Springsteen fan, got to see the boss one time from the front row. And she was very excited that he sweated on her and he spit on her. I'm just warning you, but I don't think it's going to happen, okay? So just be aware. I'll try to stay back and I'll try not to sweat or spit on you. But you are in the first row, so, I guess you came late, so you had to sit in the front row. So.
Actually, Nick asked us to sit in the front row.
Wow, okay, just in case. Okay. So I'm going to share with you what's really been the major focus of the last 15 years of my research, most of it done at Northwestern, but involving definitely Framingham data. And much of the genesis of what I'm going to show you actually started when I was a fellow here. I didn't realize it at the time that this is where it was headed, but a lot of it really started here when I was training, which was really exciting. So I'm going to define for you this new concept of cardiovascular health, which probably some of you know about. And people like Vanessa and Matt and many others are leveraging this construct here already in Framingham. We're going to talk about the outcomes of high and low cardiovascular health across the life course. Why is it good to have high cardiovascular health? We're going to talk about what this means for the population in particular, if we can get more people to midlife with high cardiovascular health. And then figure out what are those determinants? What are the things that can help you maintain high cardiovascular health as late into your lifespan as possible? So you guys all understand that this is the place that defined cardiovascular risk factors for the first time in the world, in human history, right? And that really started and the major risk factors were discovered by the end of the 1970s. We knew about sedentary, lifestyle. We knew about adverse diet. We knew about diabetes, cholesterol, blood pressure, all the other things, smoking. And much of that work was done here for the first time. So that's really important. But, some of the really leading lights who discovered the risk factors also discovered that maybe we shouldn't only think about risk and future disease potential. Maybe we can think about this in the other way. Think about health. What is it about people who never develop those traditional risk factors? Why are they special? But also, what do their outcomes look like? Do they really avoid cardiovascular disease just because they don't get the risk factors, right? So I think those were important questions around the turn of the current century that were pending. And then the cardiovascular health kind of movement moved forward in 2010. Very much serendipitously, AHA wanted to create a new definition, not just focused on cardiovascular death or cardiovascular risk, but actually promoting cardiovascular health in individuals in the population. Because of some of the work that I had started here and really just unbelievably fortuitous timing, they asked me to lead a group of incredible volunteers for the AHA to define this thing, to define this new construct of cardiovascular health. And I think what's important about a definition of health, which I will get into in a second, is it's not about future. It's not about risk. It's not about potential for disease. It's about how I am today, right? Now, how I am today certainly is linked to all those other things, but how can I actually measure and quantify what my health is today? This was kind of a new question in 2010. People hadn't really thought about it in a quantifiable way. You know, we kind of know what health is, right? Health is more than just the absence of disease, which we'll get to in a second, but there's a lot of other things to it too. So anyway, this is the paper we wrote. If you are ever having trouble getting to sleep, this is like hitting you on the head with a rubber hammer. Like, there's some good stuff in there, but we had to cover a lot of ground, so it's really long. So anyway, that's my recommendation for you if you need healthy sleep. So how do we define the ground rules? Well, again, health is more than just the absence of disease, right? Yes, sure, it's the absence of disease, but when you say I feel healthy today, you're not saying I feel healthy because I'm not having a heart attack. You're saying I have a sense of well-being. I have a sense that I can accomplish what I want to accomplish. You know, I'm able to do things both physically and mentally that I want to do, right? So we want to try to capture some of that. We, of course, as always with the AHA, we needed an evidence base. We needed published data to help us define this. And it needed to be linked, sure, to sort of not developing cardiovascular disease over the long haul, hopefully living longer, but especially living longer without cardiovascular disease and other chronic diseases of aging, and with better quality of life, right? Better physical, mental function, and better quality of life. We wanted this definition to be accessible and actionable, things that people can understand. And this was the important stuff for AHA. We had to be able to measure it, quantify it, monitor it over time, and modify it, right? So people actually could have a chance to improve their cardiovascular health. It wasn't just something intrinsic or determined, it was something you could actually improve. So with all those sort of ground rules, we then went to the literature and we looked at this. And this was a study I started when I was a fellow here and completed about a year later. And what we did was we looked at people who, on their 50th birthday, as they passed through their Framingham exam, whenever that was, when they turned 50, we just simply classified them into 5 groups. Did they have 2 or more major risk factors already present on their 50th birthday? Only one. One elevated, but not too bad risk factor. One not quite optimal, but pretty good risk factor. Or was everything, their weight, their smoking status, their blood pressure, their cholesterol, and their blood sugar, was everything truly optimal? We're talking about a total cholesterol less than 180, right? A BMI less than 25, never smoking. So those would be the kind of optimal factors. So you're in one of these 5 categories on your 50th birthday. And then we looked at what was a relatively new methodology then. What's your lifetime risk? The chance you'll develop a major cardiovascular event before you die of something else, okay? So starting at age 50, what's that chance? Well, as you can see, if you were a man or a woman with 2 or more major risk factors already present at age 50, you had a 50 to 70% chance you would have a major cardiovascular event before you die. Pretty high. Notice though, the green line, even if you have one risk factor that's not quite optimal, not elevated enough to treat, but not quite optimal, you still had a lifetime risk of around 30%. Pretty high, right? Higher than I'd like to consider. But these are the special people in that light blue line. If you made it to age 50 with all 5 of these things at truly optimal levels, it was really rare that you were going to develop cardiovascular disease during your remaining lifespan, right? In the absence of those known traditional risk factors defined here in Framingham, cardiovascular disease is actually quite rare. It doesn't tend to occur. So all this stuff about, well, we don't know what causes heart attacks and strokes, baloney. We know exactly what causes heart attacks and strokes in the vast majority of people, right? So we just need to do a better job at getting more people to midlife so they can win the game, right? Okay. Similarly, this is some work done at the Harvard School of Public Health with the Nurses' Health Study. And they said, well, what about other things like lifestyle, diet, physical activity? They also included lean BMI, but also smoking. And this was interesting. So in 2000, we thought alcohol was good for you. So they actually included, drinking a half a glass of wine or more per day as a positive behavioral health attribute. Interesting. We wouldn't do that today, but they did. And so what they said was, well, if you had 3 of these healthy behaviors over 16 years, you were about 57% lower chance of developing cardiovascular disease. If you had all 5, you were at 83% lower chance. So notice we're starting to think about this as a package, right? If you can have a package of these elements present, again in midlife, you're going to kind of win the game, right? You're more and more likely to win the game. And so we kind of took all these data and other data and put them together, and we defined an ideal state of cardiovascular health, which is optimal levels of these 7 factors, right? But we also defined the full spectrum, because very few people, honestly, at age 50, have this ideal state or optimal cardiovascular health. So that came to be called Life Simple 7 in 2010 when this first was created. And here's I'm not going to go into this in detail, I promise, but here's the definitions for poor, intermediate, or ideal levels of each of those 7 factors, okay? So whatever you like, whether it's for adults or kids, you can actually define cardiovascular health and start to give points, right? So if you give 0 points for a poor, 1 point for an intermediate, 2 points for an ideal, you can start to create a score, right? You can either just count the number of ideals, which would be 0 to 7, or if you use that 0, 1, 2 scoring and just add up the points, you could have 14 if you have all 7 metrics at ideal levels, or 0 if you have all 7 metrics at poor levels. Make sense? So I'm going into this detail because I'm about to show you some interesting data about what happens at different levels of cardiovascular health point scores. Okay, so let's look at this kind of from a life course perspective. What happens if you're an older individual based on your cardiovascular health score? So these are data from the MESA study, the multi-ethnic study of atherosclerosis. I guess one of the grandchildren of the Framingham heart study in terms of cohorts. They were mean age of 65 at start. So they were older Americans. And here's your 14-point score along the x-axis. And you can see this really nice log linear relationship. The higher the cardiovascular health score, the lower the risk that these people were going to develop cardiovascular disease over, at this point, follow-up was about 12 years. So it works in older people. High cardiovascular health means less cardiovascular disease down the road. In middle age, this is the atherosclerosis risk in communities, one of the children's studies, I'd say, of Framingham. And here the mean age was about 55 at entry, so middle age. Middle age, by the way, is always 2 years older than me. So anyway, so 55, solidly middle age. I'm sadly over 55 now, but that's okay. So if you had 0 of these ideal metrics, that was the highest risk group. That's a hazard ratio of 1. If you had 1, just 1 of those 7 at ideal levels, and by the way, it didn't really matter which one. If you had 1, 36% lower risk for cardiovascular disease over 20 years of follow-up. And notice this is kind of this nice dose response curve. The more of these things you have at ideal levels, the better you do. Out to the very rare, but several hundred people who at age 55 had all 7 metrics at ideal levels and had 0 events in the next 20 years. We really don't see that among 55-year-old people, that nobody's going to have an event in the next 20 years. It just doesn't really happen. So they're very special, and again, kind of confirms you can keep that package intact, you're going to do really well and win the game. Okay, what about young adults? This is Cardia, again, another child study, I guess, of Framingham. These were young adults 18 to 30 years old when they entered the Cardia cohort study, and followed, in this case, for up to 30 years. And we were able to classify their cardiovascular health score as young as age 18. And what you can see is if they had high cardiovascular health, even as young as age 18, very low event rates. And these would be really premature cardiovascular events, right? But very low event rates in the blue, whereas if they had low cardiovascular health, that's low points, then a lot higher event rates in the gray, right? So even at these young ages, your cardiovascular health status is actually meaning a lot in terms of whether you could get premature cardiovascular disease. So let's go even further upstream. These are data from Nori Allen at Northwestern. And she took a number of childhood cohorts that also overlapped into middle age. And she was able to create what's called a synthetic cohort, where we could follow people. Not everybody was followed from age 8 to 55, but by creating this synthetic cohort and knitting other cohorts together, we can create these trajectories. These are actually the experiences of people as they aged from age 8 to 55 in terms of their cardiovascular health scores. Higher is better, lower is worse. Notice we are here.
It's not going to work.
There we go. We are here at age 8, third grade. And some of these kids are already declaring poor cardiovascular health at age 8, right? We're really early in the life course here. And notice, if they started high, some of them stayed high, some of them kind of fell later, and some of them fell, into sort of moderate decline. Some of them fell pretty early and pretty low, but the ones who started low only got worse, right? So these 5 groups of trajectories of cardiovascular health status through childhood into midlife, kind of define what the typical patterns of cardiovascular health evolution across the life course look like. A lot of these studies had actually measured the thickness of the carotid arteries at about age 35 to look at whether there was accelerated atherosclerosis or plaques forming in those arteries. And sure enough, depending on which trajectory group you were in based on your patterns, in fact, this looks small, but it's a very large difference in the carotid intimomedial thickness. And this would be associated with roughly a 3-fold difference in risk for stroke in older adults. So this is real. And again, this is only at age 35. So that earlier life cardiovascular health trajectory seems to be mattering a lot. So now we're going to move upstream even more. So this is a study we had at Northwestern from a couple decades ago, where they measured a lot of things about moms at the end of the second trimester of pregnancy. So they were really interested in the intrauterine environment and the metabolic status of mom and how that affected not only birth outcomes, but the early life of the offspring. And sure enough, if a mom had optimal cardiovascular health at the end of the second trimester of pregnancy, she was 8 times more likely to have a child who had high cardiovascular health at ages 10 to 14, years later, right? And the obverse was true too. If mom had very poor cardiovascular health during pregnancy, her child was 8 times more likely to have poor cardiovascular health at age 10 to 14. Now, is that, did I say that caused it? No, a lot of things are traveling, together here. So we can't say it caused it, but boy, 8 times is a pretty strong relationship. So it certainly suggests that something's happening to prime the trajectory of the health of the offspring based on the exposures during their intrauterine growth period. Okay, so from 2010 on, there were a lot of papers published about this construct, and here you just see a short list of some of the things that were associated, and basically anytime you had higher cardiovascular health, it was associated with a better outcome in whatever domain I'm showing you here. If you're interested in this, and actually this paper you might be able to stay awake for, one of our fellows just published this, Liliana Aguayo, earlier this year, kind of talking about, it was a large systematic review of all the papers that had looked at the initial Life Simple 7 construct, thinking about what are the determinants of higher cardiovascular health, why does it work, and what were the outcomes, and literally everything between the tip of your highest hair and the tip of your longest toenail is favorably affected by high cardiovascular health. Maybe not a surprise, right? Because so many of those things are in there are sort of the common soil for dementia, right? Cardiovascular disease, yes. Cancer, yes. Even degenerative joint disease, arthritis. But basically every organ system is favorably affected by higher cardiovascular health. Also makes sense, right? Because the vascular system is connecting all these things. It's nourishing all these organ systems and tissues, right? So, but really kind of a powerful statement. It was fun to do this article with her and really see the whole breadth. There were papers in here I'd never heard of or seen before, but you can see the whole breadth of the entire body and all its systems are affected by high cardiovascular health, which is good news. There are also, as she pointed out nicely, some societal benefits to higher cardiovascular health as well, and we're going to explore those in just a minute. Okay, so in 2022, after 12 years with this Life Simple 7 construct, the AHA said, okay, we've learned a lot. Let's update the construct and see if it's right for the times and has all the metrics that it needs. So we did, in fact, update Life Simple 7. It became Life's Essential 8. We acknowledged, I think really importantly, the sort of social determinants that underpin, that are really important context for Life Essential 8. If you are an individual who's trying to maximize your cardiovascular health and yet you live in a neighborhood where you can't walk streets safely to go out and do physical activity, or you can't access, fruits and vegetables that you can afford, it's really hard to actually optimize your cardiovascular health, right? So this isn't on the individual so much, that there's this large sort of policy and public health environment that surrounds this that we have to improve as well. We also wanted to acknowledge that our psychological health and well-being has a very important interplay with our physical cardiovascular health as well, right? We know that both mental health or depression or other things can drive poorer cardiovascular health, and vice versa, right? Poor physical health can drive mental health and well-being issues as well. So really important context for those things. But long story short, in addition to sort of changing the scoring to sort of spread out people and really understand differences a little bit better. So now instead of a 14-point scale, we have a 100-point scale, but we also added an 8th metric, which is sleep health. Not surprising. Often I get the question at this point, what about stress? Yes, stress is really important, and we really don't know how to measure it very well. So that's why we didn't feel like it was prime time for inclusion. Incredibly important, but we all internalize stress differently. The same stressor may mean something very different for one person versus another, and that's where it gets tricky to understand its effects on cardiovascular health. But maybe someday there will be a necessary 9, which includes stress as well. Okay, so I think you get the point. So we'll move on here. So a lot of what I showed you was a single measure at a point in time and its association with downstream outcomes, right? Here's the key question though, right? Like if I change my cardiovascular health, am I going to improve my outcomes, right? If a higher cardiovascular health score, going forward, does that actually improve my outcomes? Or can I think about this not just as 1 point in time or 2 points in time with change? Can I think about my whole exposure to cardiovascular health status as we'll call it a cumulative or an area under the curve, right? If I can accumulate more high points over time, does that help me out as well? So a couple of recent studies that we've done. So this is data from a very large database from Korea. They have a common insurance system, and as part of the insurance system, everybody gets at least one comprehensive physical examination, and most people get it multiple times. So what we were able to look at was a baseline cardiovascular health score. This is that 0 to 7 score. Nobody had 7. So we kind of lumped the points here. And then at a second examination, what was their follow-up cardiovascular health score, right? So here's somebody who started at 0 to 1 and who stayed at 0 to 1. Here's, in this cell, it's started 0 to 1, but improved all the way to 5 to 6, let's say, okay? And what you see inside these cells is the hazards ratio for developing cardiovascular disease. So again, always low cardiovascular health score, highest risk. Always high cardiovascular health score, down in the bottom right corner there, 85% lower, right? But what about the change groups? Here are people who had a lower baseline cardiovascular health score and improved it over 2 to 5 years. And notice in every case, the risk is substantially lower, right? Now, we don't know why they improved their cardiovascular health score. We don't know what they improved on their cardiovascular health score. I do, but take my word for it. It doesn't really matter what they improved. That was always associated with lower subsequent risk for cardiovascular disease. The other thing that's interesting about this is among these people who had a range of cardiovascular health scores at the beginning, if they ended up with a low cardiovascular health score, it was still way better to have started, right? Started high and gotten low, you're still better off, right? So I think what this says is it's never really too late. You should always try to change and improve your cardiovascular health score, but the earlier you start, the better. If you have high early, it's gonna sort of persist and help you have better outcomes. Does that make sense? Okay. All right. So these are data that we just published earlier this week. This is from a fellow that I was working, sorry, he's actually a medical student. What am I saying, a fellow? He's a medical student, great kid. And he was interested in this concept of sort of the area under the curve of exposure. You know, when we talk about cigarette exposure, we think about pack years, right? How many packs per day did you smoke times how many years did you smoke them? So that's a bad cumulative exposure, right? More pack years means more cigarettes smoked, and that's usually bad for your health. This is a good cumulative exposure, right? The more cardiovascular health points times the number of years you have them over decades can actually potentially be associated with better outcomes. But we're also interested in understanding not just that cumulative exposure, but you know, if you have 100 points and I have 100 points, you know, maybe I got there by starting low and going high, and you got there by starting high and going low. Does it make a difference when, you know, when that change happens, even if the cumulative exposure is constant? So what we found was basically, just to kind of cut to the chase, the cumulative score was as or more important as your score at age 45. And the slope was also important, meaning if you had high cardiovascular health early and you lost it, you were, again, better off than if you had low cardiovascular health and improved it. So the earlier, the better. Sort of a constant theme here. Okay. So what does all this mean? Let me stop for a second before I get to implications. Any questions about all that? I think you get the general gist of it, right? Okay. So these are data from a cohort at Northwestern that we've been following since Dr. Stamler started this in 1967. So it's 40,000 individuals who were employed in Chicago around 1970. And he did really good phenotyping of them. And we then subsequently were able to link to their Medicare files from about 1985 onwards. So as soon as somebody became 65, we could understand all of their health encounters in Medicare, right? So some of them were quite a bit younger, and in fact, the mean age was 42 when we first met them in 1970. So people were aging into their Medicare time throughout then the follow-up through 2015 for this study. And what we found was we kind of did that same grouping that I told you about before. People with really all optimal cardiovascular health factors, or people with 2 or more major risk factors. So just to think about these extremes, here's the start of their Medicare eligibility. The whole length of this horizontal bar is their total lifespan after age 65, okay? So for this group, the total lifespan goes out to roughly 84 years on average, okay? The green part of this bar is the interesting part. How long did they live without cardiovascular disease, okay, on average as a group? If they had, the yellow represents how long they lived on average with just one cardiovascular problem, the orange, 2 cardiovascular problems, and the red, 3 or more cardiovascular problems, okay? So on average, these people are living healthy to 76 and then living with cardiovascular disease for another 8 years before they pass. And that's what's shown here, right? That they're spending roughly 8.3 of their Medicare years, 8.3 or 43% of their Medicare years with some form of cardiovascular disease. Back here at age 42, remember, these people were all favorable. They get into Medicare, and notice their health span is actually to 83. And they spend a lot less time sick before they die. Now, everybody has to die. Sorry, but that's just the way it is. But what we see here is that not only are they living longer, but they're doing something called compressing their morbidity. They're getting sick closer to the date of death. And that's, again, I think how we really try to win the game, right? So their lifespan is 4 years longer, but their health span in this group is actually 7 years longer. So based on what they looked like back here at a mean age of 42, that's really having profound implications for not only how long they live, but how long they live healthy, right? That's sort of, it's not the life in the years, it's the years in the life concept. No, said that wrong. It's not the years in the life, it's the life in the years concept. And by the way, it's not just about cardiovascular disease. If we look at all-cause morbidity, dementia, arthritis, everything that can happen to us as we age, we again see both extension of lifespan and extension of health span, so compression of morbidity. So kind of a cool demonstration of that. Now you're asking, or you're thinking, well, if these people are living longer, we're just going to spend more money on them, right? Actually, no. These people, again, with all favorable cardiovascular health factors back at age 42, we spend on average about $75,000 less in them in 2010 dollars during their Medicare lifespan than people who had risk factors back at age 42. So this might be a way to save some money, right? If we can get, again, more people to midlife with higher cardiovascular health, 20, 30, 40 years later when they're in Medicare, we're spending less money on them, even though they're living longer. So kind of interesting demonstration of that. And this just kind of shows, the sort of life year gain, if you will. So as you can see in the top, moderate versus low cardiovascular health, you're going to gain 6 or 5 years of life by having moderate versus low cardiovascular health at age 50 in the US. If you have high versus low cardiovascular health, again, 7.5 or 9 years of life gained. So pretty substantial. And this is the interesting thing about this paper. It's not the gain in cardiovascular disease that's driving most of that. It's the gain in non-cardiovascular diseases that we're not dying from, like cancer, like dementia, right? So yes, huge gains in cardiovascular disease, but even more gains in non-cardiovascular diseases related to having high cardiovascular health in midlife. Okay. This kind of shows the same thing. So here are those horizontal bars again. And again, you see sort of total lifespan is the whole bar, and then the health span is the dark part of the bar, right? And so what you see here is that for men and women at ages 50, 60, or 70 in the UK Biobank, you see that same sort of compression of morbidity, extension of health span kind of pattern, whether it's CVD, dementia, cancer, or diabetes that you're worried about spending time with before you die. Okay. So then another one of our fellows, Josh Bundy, at the time did this kind of simulation exercise. If we could magically snap our fingers and give every adult in the United States high cardiovascular health, just like that, congratulations, it's done. We would actually prevent 2 million heart attacks and strokes every single year in the United States, is what he would project. And even if we weren't quite as successful, if we snapped our fingers and only 50% of adults magically had high cardiovascular health, we would still prevent about 900,000 heart attacks and strokes every single year.
Amazing.
Thank you. Your mic's on, but pretty.
Yeah, I agree.
Pretty cool. And think of think of the lives saved here, and think of the quality of life saved here, but also think about, just frankly, the money that could be saved. With 2 million fewer heart attacks and strokes, if they cost on average $50,000 each, that's real money pretty quickly. So I think you get the sense here, right, that if we can actually prevent the development of the risk factors in the first place, that's how we really win the game, right? Get more people to midlife with optimal cardiovascular health, not having elevated risk factor levels. That's where we can really make the biggest difference. Once risk factors are there, we have very effective treatments for them, but the horse is already partly out of the barn, right? We can't restore the optimal low risk of people who have high cardiovascular health. So this sort of newer concept of primordial prevention is really important, right? Don't let the risk factors develop in the first place. Okay, so this is what we really want to know, right? Okay, if you believe me, then you probably want to be interested in, okay, how do I get there, right? What are the important determinants of maintaining cardiovascular health? Well, for most of us, we have our highest cardiovascular health at birth, and it tends to only decline as we eat more Doritos and don't, do enough physical activity, or perhaps, smoke, or do other things, who knows what. Or again, are exposed to toxins in our environments that are out of our control, right? And so in general, we see that, at birth, cardiovascular health tends to be its highest. By middle age, high cardiovascular health is pretty rare, unfortunately, in our society. So the question then is, well, does it have to be that way, right? Is this our destiny? Do our genes just kind of poop out and everybody's going to develop hypertension, or everybody's going to develop bad cholesterol or diabetes or whatever? Or are there things here that are in our control? And I think you can probably guess the answer. But again, here's the point, that at ages 12 to 19, only about 40% of teenagers have at least 5 of the 7 metrics at ideal levels, right? By the time we get to age 60, vanishingly rare, right? That people have 5 or 6 metrics at ideal levels. So we're losing a lot of cardiovascular health across these age zones. And can we do something about that? Well, moving upstream a little bit, this is actually data from Cardia looking at, again, what are the trajectories through early adulthood of cardiovascular decline. And there are some people who stay in the green zone and don't really lose much cardiovascular health at all. But the vast majority of people do this. They're losing their cardiovascular health as they age. Okay, so we came back to our friends at Framingham and said, you have the optimal design to determine how heritable cardiovascular health might be. You have 3 generations of related people, all of whom have been phenotyped in a way that we can actually check their cardiovascular health score in midlife, and then try to calculate how much of that might have been inherited and how much of that might have been influenced by behaviors, environmental exposures, everything else. So using this design, we can calculate the heritability is somewhere around 10 to 20%. Now that's statistically significant. That's actually reasonably high. But it also tells you that 80 to 90% of your midlife cardiovascular health is not heritable. It's something that you're exposed to or that you're doing. So that's one way to look at this and perhaps provide some hope. Here's another way to look at it. So going back to our Cardia study, we looked at whether lifestyles could help you preserve higher cardiovascular health into midlife. So here are those lifestyles again. We actually included no alcohol intake because it was a few years later now. But notice, those same sort of 5 healthier lifestyle approaches that might help you think about achieving higher cardiovascular health. And sure enough, it did work. If you followed 0 or 1 healthy lifestyle through young adulthood, the chances that you would make it to midlife with high cardiovascular health, about 2 to 3%, not very high. If you followed all 5 of those healthy lifestyles, then about a 50 to 70% chance that you made it to midlife with optimal cardiovascular health. So remember, what happens after that is you win the game, right? You live longer, you live healthier longer. So it seems like a lot of this may be in our power to control. Okay, so let's think about these 2 things together. This is a fun study done by a junior investigator at UT Houston. And she used ERIC data, and she looked at the polygenic risk score that's been developed in the UK Biobank. 6 million different variations across people's DNA, right? All of which are related in some way to cardiovascular disease. Blood pressure levels, cholesterol levels, blood sugar levels, or heart attacks, strokes, heart failure, the actual diseases themselves. So, if I created a score for George, he would have 6 million different points that would add up to his point score on this polygenic risk score. So we can put him in a bucket of low, intermediate, high. Sorry, George. You look like you're doing well, though. So, yeah. But we can also calculate a cardiovascular health score from these ERIC participants. So we can look at, what's the influence of genetics, what's the influence of more, environment and behavior. And each of those things separately, each of those scores separately did what you thought it should do, right? If you had high genetic risk, higher event rate. If you had low genetic risk, lower event rate. And likewise, if you had high cardiovascular health, you did good. And if you had poor cardiovascular health, you didn't do quite as good. So separately, they're working the way we think they should. So what happens when we put them together? Who wins? So you guys are now familiar with these horizontal bars, right? We have lifespan is the total bar, and health span is the black part of the bar, right? And then the gray part is time with disease, in this case, cardiovascular disease. So let's just focus on the top and bottom rows. Up here, we have people with a low polygenic risk score, good genes, but poor cardiovascular health. Let's call it bad lifestyle for short, okay? Good genes, but bad lifestyle. Down here, we have people with bad genes, but good lifestyle, okay? So kind of the 2 extremes. Notice, if you have bad genes, but pursue healthy lifestyle, have high cardiovascular health, on average, those people lived 12 years longer. On average, 19 years fewer with cardiovascular disease, and on average, 7 years fewer with cardiovascular disease. Pretty powerful. Now, these people were not randomized to these things, right? There may be many reasons for why one is in one group or another, but still pretty powerful, that perhaps the lifespan and the things that, the lifestyle and the things that you can do to improve your cardiovascular health may mitigate some of the risk that you inherit from your genes, right? And so again, the earlier you can do that, the better. Now, this doesn't say genetics is wrong. It's absolutely not true. But it does say maybe we ought to be finding those people early in life who have inherited, a mix of genes that might put them at risk, because they're going to particularly benefit from healthy lifestyles. So if we could target them early, maybe we really could mitigate some of the risk that they inherited, right, just by chance. Okay, so I think you get it. I want to stop so we have time for questions. But cardiovascular health is heritable, but relatively modestly so. It's clearly modifiable. Never too late, but the earlier you modify your cardiovascular health, the better, it seems to be. Healthy lifestyle through young adulthood. Was there ever another answer? Maybe we can overcome adverse genetics. So that sort of primordial prevention approach, where we don't let the risk factors develop in the first place through healthier lifestyle, starting as early as we can in the lifespan, really does seem to pay huge dividends. So I will stop there. Happy to take questions, and thank you so much. I hope that was useful. And a big thank you to Nancy. I think it was Nancy for her endorsement.
Yes, that was me.
Sounded like you. Any questions?
Sort of, I think, vexing question in internal medicine, primary care is raised is when to start treating hypercholesterolemia, right? Because you make a big deal about the earlier you can attain cardiovascular health, the better. But it's so common, of course, to have a little bit elevated cholesterol level. But if you follow the AHA guidelines, you don't get started on a statin until your 10-year cardiovascular risk is such and such. So does that paradigm need to change, and we need to be starting 20-year-olds on statins?
I think it does. I think this sort of concept of the area under the curve of exposure, or the cumulative exposure, works for most of the things that we're exposed to, right? It works for blood pressure, it works for cholesterol, works for blood sugar, even starting well below the levels where, again, we would say, oh my gosh, this is clinically elevated, we have to treat you now. That time spent with elevating risk factor levels turns out to be critically important. This is a really hard thing to study, as you know, right? Who's going to do a trial where we put 20-year-olds on a medication for life and wait 20, 30 years to see if they have fewer heart attacks than the people we don't put on the medication at age 20? That's certainly well beyond the NIH funding cycle of 5 years, right? So it's really hard to study, but all of the epidemiological data and a lot of the sort of animal-based data and other observations that we have would suggest, yes, if we were to intervene on people, let's say, in the top decile or top 10th percentile of LDL cholesterol or ApoB levels much earlier in life, we could really chop off that part of the impending risk pyramid pretty substantially, right? Because again, they're accumulating that dose of area under the curve exposure. So I think it's true. It's just hard to show it directly. And I think that's where the guidelines get tripped up, because they have to have direct evidence to make a recommendation, especially for medical therapy. There's new cholesterol guidelines coming in a few months. And I think everybody on the panel would have said, yeah, what George said. But then we got to go find the evidence for it. And it's indirect, I think, to say it fairly. Other questions? Yeah.
Do you think, going back to the study that you mentioned that was done in Korea, do you think that implementing or having insurance companies be mandated to provide 2 comprehensive physical exams per year, do you think that would greatly reduce and at least assist with both like the cost of like Medicare later in life, as well as just insurance costs in general? Do you think that would help people both cost-wise, but as well as like health-wise for cardiovascular risk?
I do. And the reason I think that is because one of the major places I think we fall down is that we don't screen people, and we are not aware that they are accumulating risk to these exposures, right? So many young people, women much better than men at getting to some primary care visit of one shape or another, right? But so many young people don't routinely have these things measured, or even at all, right? In truth, to George's point, we should measure cholesterol in every child by age 8 to 11. And if they have a family history of high cholesterol or premature cardiovascular disease, we should measure by age 3, right? Huge missed screening opportunities here, where we're just not aware that somebody's accumulating risk, and then they show up in the emergency room with a heart attack at a young age, or maybe dead, and all that could have been prevented if we'd just done the screening. So I think it would help a lot. We would capture people that we need to be paying attention to much more effectively. In our system, where people switch insurance every few years, insurance companies aren't going to pay for that because they're not going to see the benefit from it, sadly. But Medicare would absolutely see the benefit from it, just as you pointed out, just because the chain follows logically. Yeah.
Do you think, so those principles, those 7 simple things seem very clear tenets, but like I look at my son and I think his lifestyle is quite a bit different from even my parents and mine, in that he drinks less, but and he doesn't smoke, but there's like the pouches and vaping, and there's now more, smoking pot and everything like that, which I know they do studies on, but do you think that changes the trajectory at all of all this, or you can still bundle it in together too?
It's a really wonderful question. I think my answer is yes and no. I think, if we were crafting a risk score, then yes, we have to, we know this, we have to weight things differently for today's generations than we did for 1970s Framingham generation, right? Where they'd been born years earlier, much more smoking, much less obesity. Like things have just changed in terms of what they're exposed to, what the population looks like. So if we're trying to precisely calculate who will develop disease, then yes, we would have to kind of wildly change this. But we're actually trying to say health, right? And so we ended up not weighting each of these now 8 things. They're considered equally because we're trying to think about the life course. And it turns out when we look at this, if somebody younger changes their diet, over the long haul, it has just as much impact as it could if they stop smoking or drop their blood pressure. Now, in the short term, smoking and blood pressure will have a much more rapid effect. But over the long haul, diet will work through their weight. It'll work through their blood pressure. It'll work through their sugar status, whatever. And it can have a pretty profound effect. So, so thinking at it from this health perspective, as I said, it doesn't really matter what you pick if you've got time, right? Yeah. Yeah. So, no, that's right. It's impossible. No, it's impossible to focus on 8, right? It's impossible to focus on 8 things. And so, when we talk about this in clinic, we say, what's the one thing you want to work on? Because it's gonna provide dividends no matter what it is, because all these things are kind of interconnected. Sure, please.
I have a question about the scoring system. Well,
Yes.
It seems like that on population level is working great. But when we look at each of the individual components, it seems like there are much more nuances. For example, sleep, we're accounting for average, duration of time in bed. What about the quality?
Yeah.
Physical activity, same thing, intensity, timing of it. So I'm wondering, now that we have variables and we can begin to actually measure these things, how do you envision the scoring system to change in future, if at all?
Yeah, so you've clearly looked under the hood of how we score now for the Life's Essential 8, the 0 to 100 point score. There were a couple things that went into that. 0, 1, 2 scoring with the initial Life Simple 7, it's a little bit too simple, right? Meaning, best example, if you did 0 minutes of moderate to vigorous activity per week, you got a score of 0. If you did 150 minutes per week, you got a score of 2 in the old system. So if you did 1, or if you did 149, you got a score of 1. Those are very different people. And especially the poor guy who was doing 1, changed his entire life, is now doing 149. His cardiovascular health score didn't change, right? So part of the scoring update was really to reflect, can we detect differences between people better, and can we give people credit for improvement better, right? So that's maybe the best example I can give you. But it is a little complex, and we tried to think for each of the 8 metrics, not just what do we have and what do we know about in that domain. So we switched from total cholesterol to non-HDL cholesterol, for example. We introduced sleep, and what we have pretty reliably both in the ability to measure it and the ability to understand its relationship with long-term outcomes, is sleep duration. Data are coming about sleep quality for sure, and I think that will be a great upgrade. You know, in 10 years when I'm dead and somebody else wants to do the necessary 9, have at it. You know, like that's you. So I think it's a concept that should continue to evolve. You know, we try to do what's easily available, measurable, monitorable over time, modifiable, but that will change as we, you know, learn more. So for sure, great question. Excellent. Thank you all so much. Really appreciate it.